Good afternoon. Welcome to the webinar on the in-home therapy practice profile. I'm Jack Simons. I'm Director of the Children's Behavioral Health Initiative at MassHealth. And I'm here with Kelly English and Susan Maciolik from the Children's Behavioral Health Knowledge Center at PMH, also Bonnie Saulnier, who's the principal author and editor of the practice profile and took them through many, many revisions in response to feedback. So this afternoon, we're going to talk about what the practice profile is, describe the reasons for developing an in-home therapy practice profile, and then talk about steps that we took to arrive at the current draft, and where we expect to go with the practice profile from here. Thank you. So, as everyone knows, in-home therapy is a great opportunity to work with families, but it's hard, complex work. And over the many years that we've been doing case reviews of intensive care coordination and in-home therapy, one of the things that we've seen consistently over the years is a high level of variability in the effectiveness of in-home therapy as we practice it here in the Commonwealth. We have often heard from providers, I wasn't really trained to do this, I'm having to improvise. We've heard there's guidance but not enough about how to do this work really effectively, and we've also heard from many clinicians and PTNSs that they wish there was more training on how to do it. As we thought about how we could give people what they need, the tools that would make them really effective at in-home therapy, we had conversations with Dr. Allison Metz at the National Implementation Research Network at University of North Carolina. And she led us to understand that before we go ahead and do training or other kinds of intervention supports, we really need to define very carefully exactly what good IHT looks like. And that is why we have a practice profile. It's to give us a very detailed description of how to do IHT effectively. So having briefly described the reason we're doing this, Kelly English is going to talk about what a practice profile is, and then you'll hear about the steps that we've gone through and preview the work we're going to do in FY17. Kelly?
All right. Thanks, Jack. So I'm going to talk a little bit about background information about developing the practice profile. So for any program or practice to really achieve significant impact, it needs to be well specified and defined so that the practitioners who are actually responsible for implementing that intervention know what to do in order to deliver or carry out that service. And so one of the first things you need is a really good description of the program. That includes defining the philosophy, values, and principles that kind of undergird that program, because those are often really clarifying for people. They serve as kind of that guiding light. They're aspirational. So having those well-defined is important. And for CBHI, those are kind of well-articulated and known. So we kind of led with those. Another aspect of kind of defining IHT, you know, we're part of the development of the medical necessity criteria. For any service that you're going to go out there, you need to know who's this service appropriate for, who's kind of included in that service, and who shouldn't be, who isn't the service for. So development of those clear participant inclusion and exclusion criteria. So we had that first kind of bucket already well defined for IHT. We had performance specifications written for this service as well. The next part of defining any kind of service or program is being clear about those essential functions that make up or define that program, so that you know what activities or key features or hallmarks of that program or practice. And so you'll hear my colleague Susan Maciolo talk about this in a few minutes about those core components that we arrived at as part of the development of the IHT practice profile. And then the next step was, once you've defined those core components or activities, is to go even further and drill down into what are the operational definitions of those essential functions. So what do those core activities look like, down to the level of saying and doing. And it's really this operational definition of the essential functions that really are the heart of the practice profile work. And that's the really important key ingredient, is getting down to that level of saying and doing to promote consistency across practitioners at the service delivery level. And then ultimately what you hope as the next piece of the puzzle is to once you've defined the what, is to create fidelity measures that can be used to kind of help improve practitioner competency and define where are areas to get better. But ultimately what we were really trying to do here was create something that could be teachable by a supervisor or a skilled clinical teacher, and break it down enough so that it was learnable by a new staff person who was coming into the role of doing IHT work, and that they could go out then and do that work with the kids and families that they're serving. So on this slide, you'll see kind of what are those core features of the practice profile. So this is kind of a template of what a practice profile would look like. So at the top, you have the definition of the core element. So, for example, that would be a definition of a core activity. In this case, one of those core activities was engagement. And then below that, we have how does engagement contribute to an outcome in IHT? And then even further drilling down, what we want to see is, what does that practice look like when it's being done ideally? And we use that term ideal deliberately. So some practice profiles use the term expected practice. We chose to use the word ideal because we saw this column as really describing the quality and performance of what we were aiming for. Then in the middle, we attempted to clarify in a practice profile kind of developmental use in practice. So what does engagement, for example, look like when it's a developmental or emerging skill for somebody? So it's something that they may do inconsistently or some of the time. And when it's a developmental practice, it really indicates the need for, this is where most of the supervision would be happening for somebody, and coaching them to get better so that they can move eventually into that ideal practice category. And then finally, what does the core activity look like when it's an unacceptable use in practice? And if you're seeing a lot of kind of folks that are falling into that unacceptable practice category, it really indicates the need for maybe some more organizational or system strategies to better support individual practitioners. Maybe everyone across the board never learned the skill, so we need to go back and how do we help support our staff in that area. So it really gets you clear about what does it look like when it's well done, when it's an emerging skill, and what does it look like when it's a kind of, you don't want somebody to ever practice in that way. So why do a practice profile, and what are some of the benefits? So once you're really clear about the what of the service, it can help you, it can help programs develop more effective training protocols, coaching and supervision strategies, and fidelity assessments, because you're clear about what you're training to. It can help you understand areas for improvement. It can help to increase the ability of the program or practice model to be replicated in a new setting with new staff. So it helps promote consistency across new contexts. And we know that there's often new staff coming into these programs, it's unfortunately a common occurrence. So having something standardized that you can use to train people up to that's clear is another real benefit of having a practice profile. So another benefit of this is that a well-operationalized intervention can help organizations develop decision support systems we find their administrative practices to really, and develop systems partnerships that are really aligned to support this new way of doing work. And really, it ultimately can help ensure that your outcomes are accurately interpreted. So outcomes can be challenging to interpret when there's a lack of clarity about the what. So this next slide walks us through kind of the development process. You'll see that we started back down this path in September of 2015, where we started doing some initial reviews of some of the existing documents out there. And you'll see now we've gone through several iterations of work groups, a literature review that you'll hear more about in a moment. And now we're about ready to emerge into the summer months here, doing some more focus groups with supervisors and clinicians. We're doing this webinar today to kind of get all of you up to speed about where we are. So it's been a many months in the making here. So just I mentioned earlier that one of the core activities of developing a practice profile is to dig back down into some of the foundational documents. So you'll see here we have the Mass Health Program Standards or performance specs. We used the practice guidelines. We built upon those. And also we did some work looking into the Mass Practice Review to try and use that as, again, to kind of build from this practice profile. So we didn't create it out of nothing. We used some of those existing documents that many of you have seen to start us down this path. So next up, I'm going to turn it over to my colleague, Susan Mathiolic, who's going to talk you through more of the ongoing development process.
Hi, everyone. Nice to be with you today. I'm going to talk a little bit about how we launched this work within the IHT community, how we brought it forward. We started in November 2015 with a kickoff meeting, and as Jack said, we started the conversation with Dr. Allison Metz, who's from the National Implementation Research Network, and in the spirit of wanting to be as transparent and building capacity throughout our system as we can be, we brought her into to a day-long meeting with folks here in Massachusetts. We spent a day with a group of IHT program directors and supervisors, some representatives from the MCOs, the court monitor, and ABH all joined us for a day-long, really working session. We wanted to make sure that everyone understood where we were coming from in terms of building on the expertise of the National Implementation Research Network. Some of you may have been on previous webinars with Dr. Metz and some workshops that we've sponsored through the Children's Behavioral Health Knowledge Center. There's a lot of information on the Knowledge Center's website if you're interested in more about that group. The purpose of the day was really to start to dig into the core components. As Kelly said in the previous slide, we started with the core components, and we drew from those foundational documents to identify what we thought were the core components that emerged from those documents, and then asked the group to really test that idea and see if those were in fact the right core components for going forward. So we had Allison present the practice profile methodology and approach. We shared the initial draft of the core components, and then we did some small group work, which I'll describe in the next slide. So here's where we started with the initial core components, and if you were to sit and read as our wonderful colleague Bonnie Saulnier did, looked at the practice guidelines and the program standards and some of the results from the case reviews, this is what emerged as the core components of in-home therapy. We handed this to the small groups, and we asked them each to consider whether those core components with about a paragraph of a definition were in fact part of what they understood to be in-home therapy as they practiced it and managed it and hired into it. And we asked them if they were the components to say either yes, that we got it right, or yes with some modifications, or no, that they really weren't the right way of understanding in-home therapy. And as a result, we ended up with a more robust list. So we have a revised set of core components that emerged from that meeting. And I think you can see from the way they're even articulated on this list that the conversation identified a more robust and really more complex way of understanding the work of in-home therapy. So some of the things that remain the same, you can see the beginning and ends, the bookends of the program. You know, practicing with cultural relevance, still very important on both lists. Engaging, exiting were some of the themes that continued. But you'll see in the middle some of the ways that we began to unpack what is at the heart of what IHT clinicians and DTNS practitioners do. And so two themes emerged from that. And what we found as a group was that really the documents as they had been evolving put too much emphasis on the care coordination process and not enough on the actual treatment that goes on in home therapy, and that we needed to draw a clearer distinction between IHT and ICC. So if you look at the initial core components compared to the revised, you'll see that we collapsed some of the what might be called the ICC-like functions that IHT might do as a hub, or even some things that you don't do as a hub, but as a matter of good practice in terms of care planning and care coordination. And then really in the revised set, begin to unpack some of the clinical work, some of the risk assessment and safety planning, the intervention planning, and the actual treatment that goes on in in-home therapy. So we thought this is a really important and productive day for us. We took these revised core components and then began to plan even more detailed set of working sessions, which are begin on the next slide. So from January to April, we had 10 work group sessions. We devoted a half day to each of the core components, except for these two that are mentioned in the second bullet, practicing with cultural relevance and intensive therapeutic intervention. Those were really not just particularly important, but rich and complex work, and we devoted a full day to each of those. So you can envision the amount of time that we spent with folks from the in-home therapy community, really exploring what the work is of each core component. And it, Kelly mentioned, what are people saying and doing when they are doing these components out in the field. Participants included, we had a wonderful array of participants. We had a total of 42 participants drawn from an array of providers. You see there are 22 providers, a couple of MCOs, court monitor joined us for several of the sessions. Each session had about 10 to 17 participants, and some attended just one session, some attended all the sessions. On average, they attended 3 sessions each. We really wanted to get a variety of perspectives, and it's important to note these folks were representing not their agency per se, but representing good, strong IHT practice at a variety of levels in a variety of places in the Commonwealth. And so we were very fortunate to have them spend as much time with us as they did. Also there, Jack alluded to at the beginning, the project team. So those of us on the phone have been joined by Jennifer Halsey and Laura Conrad, who are not able to join the webinar today. They're equally important members of the project team. And we've really spent a lot of time together making sure that we structure this project as productively as possible, because we're mindful of the valuable time that we've gathered from everyone who's participated, and we wanted to make that time as effective, efficient, as productive as we could. Because, as Jack said, this is a really important initiative. Mass Health and the Knowledge Center have invested a lot of resources in it. We think IHT is an important part of the system, and so this project team is really honchoing this forward. We continue to meet and will continue to meet to do some of the work that we'll talk about later in the webinar. So the next slide gives you the work group schedule, so you can see how intensively we met. It was close to every other week. Wednesdays were our day. We were very fortunate not to have any snowstorms getting in our way, so we were able to take that last day, April 7th, and really devote it to a more in-depth discussion about practicing with cultural relevance. And for those of you who have participated in some of the trainings that Dr. Ken Hardy has done, we were fortunate to have some of the folks who have been in those sessions join us, and we were really able to benefit from other projects and other investments in IHT quality improvement work. So the next slide gives you a list of all of the providers who were kind enough to lend us their staff for this initiative. We really give them all a big thank you. You'll see that there were providers of varying sizes, a variety of geographical locations, serving diverse communities. We really can't thank them enough for the effort and the commitment and really the deep engagement in the process. People were really very committed to it, and we would not be as far along as we are without that effort. I think you'll understand what kind of commitment it took as we describe in more detail what those work groups look like, and for that I'm going to hand it off to my colleague Brian Saulnier.
Hi, and thanks everybody for being here. At each of the work groups, we distributed a copy of the first draft of the elements that the group was working on. And that first draft included the definition, the contribution to the outcome, and a column of ideal elements that fit that component. The definition is rather clear. The contribution to the outcome, I just want to say, means how this particular component enhances child and family well-being and how it promotes the vision and values of CBHI, which is the overarching frame in which in-home therapy operates. So we passed those out. The full group then reviewed the definition and the contribution to the outcomes and gave either a endorse or thumbs up, a not endorse, not good, thumbs down, or a request for clarification on the definition and the contribution to outcomes. So there was an opportunity to discuss those further at that time. They then reviewed the activities in the ideal practice column. So each, on the left-hand column of the template, there were rows indicating what activities constitute, or a first draft of what activities constitute that particular component. Again, everyone was asked to give an endorse, a request for clarification, or a not endorse, which we asked when people couldn't endorse the item for them to also make suggestions about the changes that would help. Rather than just say, no, that's not good, we asked for suggestions. Okay, how would you say that? What would be a better way to frame it? What would you add? What would you take out? And so forth. When every participant had voted and the item and everyone was able to endorse with whatever changes had been made, we moved on. So there was really a consensus building process at every step of the way. We then broke up into small groups, and each group, sort of randomly assigned groups, were given a set of usually 4 to 6 of these items to go into more detail in a small group environment to discuss those. So the specific task was to fill in the developmental and the unacceptable columns. However, what we found in doing it was that as we looked at the developmental and the unacceptable columns, we also had to go back and make some revisions to flesh out the ideal columns. So again, there was a lot of good thinking and process there that influenced the ideal practice as well. A note taker was assigned for each of the small groups, and when their work was completed, each small group reported back to the full group. Again, there was then discussion or questions about what came up. And finally, all of the notes that the note takers took were collected, gathered together, and anyone else who took their own notes was invited to share those. So we gathered all of the notes that people wanted to share from the entire group and took those back to work on the revision. The writer, and I can say this with all truth because I was primarily the writer in this, I took every single paper that had notes on it and looked at every single comment and every single suggestion to try to make sure that we were really incorporating all of the input we got from those very hardworking groups. So I'm going to show you next a little bit about that process. This first slide shows just one of the components, the assessment and clinical understanding. At the top in italics is the definition, and there's the contribution to the outcome, and then there are the blank columns for ideal, developmental, and unacceptable. So you heard about how we revised the top areas, the definition and the contribution to the outcome, and I will say that those revisions kept going throughout this process, which is not finished yet. This slide shows what people were given at the work groups. So the definitions at the top, and then the column of ideal elements down the left-hand side. This shows an example of the kinds of revisions that were made. So in red here, you see some suggestions for the outcome. You see how the developmental and unacceptable columns were filled in, and you see how that also drove changes in the ideal practice column. Finally, when all of those revisions were incorporated, and we felt that we had really fully vetted everything that people suggested, we took the drafts and tried to fit them together, because many of the themes that occurred were actually crossed between components. So you couldn't exactly say, well, these things only fit in assessment and clinical understanding, they don't fit anywhere else. So we tried to cross-reference, tried to make sure that we were referring to the places that, to the other components where these definitions would become fuller. And we also tried to make the rows, tried to clump together things so that the rows showed sort of topic areas rather than every single individual action that we had started out with. So this gives you an idea of where we are with that. These are also now available on the CBH website, Knowledge Center website, so you can see obviously much more about them there. Some of the insights that we drew from this process were the very encouraging insight about the high level of consensus about what constitutes quality IHT. There were a lot of wonderful suggestions in the group, but there was not a lot of difference about what the actual work is. There were many great suggestions about how to describe that work. For example, this is one of many. Often in the first draft, the rows said, ask the family about this, or ask someone about that. And there was a strong sense from the group that we should change that word to explore with the family this, which softened it, broadened the topic, made it a gentler way of describing it. So that was a very helpful improvement. Didn't change what we're doing, but changed the tone of it and made it better. I have to say that there was one of the takeaways for it was the second one, which was the benefit of the very knowledgeable and skilled practice leaders in that room. It was a room full of great minds and generous hearts that put this together. We also noticed, as I mentioned already, that the development of the full draft meant cross-checking for repetition, it meant cross-referencing among the components, and it meant trying to balance enough items to be inclusive and descriptive of the process while also leaving enough room for the individuality of every family situation. We did not want this to be a formula that had to be applied to every family. It needed to be broad enough also to leave room for the variables that happen with each family. The core components and activities are not linear. It's not a to-do list. It's not a substitute for the art of the work. And obviously not every item will happen in the order that they're listed in those components, and not every item will apply to every family configuration. And then finally, we realized we needed to carefully, in some of the components in particular, distinguish between how IHT is practiced when it is the hub service and how IHT is practiced when it's working with intensive care coordination. A result or an insight that's not listed here, but one which I think we have marveled at as we've gone along, is just the great sense of collaboration among all of the people that participated in this. So I'm going to hand this back to Jack now to talk about the next stage of the work.
Thank you, Bonnie. So before I go further, I just want to say, from a Mass Health perspective, we're incredibly grateful to the Knowledge Center for the role they played in this collaboration. It's been great, and I also want to echo Susan and Bonnie in thanking all the work group members who gave us such a high level of expertise in this process. So we had an expert consensus, but we also wanted to make sure that the practice profile was consistent with the evidence base and the research literature. So we had Dr. Joyce Taylor from Springfield College School of Social Work do a literature review, and it's only 6 pages long. It's very readable. It's on the website along with the practice profile components. So you may want to look at it. And what it really does is go through each component and look at how it lines up with what is known in the literature, both the peer-reviewed research literature and also expert opinions in textbooks and the like. And in general, what Joyce found is that what we're doing in Massachusetts with this practice profile is very consistent with best practices from the literature. There are a whole lot of areas where the literature is silent on how to do things, and there we have practice-based evidence. We have the expertise of our practitioners to fill in the gaps. So I'd really encourage you to go and look at that. Okay, and now to talk about where we are. This slide, completing the practice profile, has 2 parts. The final review is now done. We sent out the components to all work group participants and asked them for any further revisions they wanted to suggest. Once again, Bonnie incorporated some new suggestions, although by this point there was a very high level of consensus and agreement. That work was done in the middle of June. And now we move to the next stage, which is the focus groups. I think we've done 1 already, but they will continue during the course of the summer. People from our team are going to be going out and meeting with IHT practitioners, supervisors, but also clinicians and TT&Ss at staff meetings in a series of focus groups to discuss whether the components of the practice profile really make sense to people, whether they are in fact teachable, learnable, and doable. So we're going to have yet another round of feedback, this time from people who are doing the work on a daily basis. And now Kelly will take us to the end.
All right. So those of you who have been on a Knowledge Center webinar or gone through our website may be familiar with the triangle that you see up on your screen there from the National Implementation Research Network. But this is really going to be orienting our work going forward into FY17. So as we spent the last year kind of really getting clear about the what, now what we're going to be focusing on is the how, or how are we going to implement what we just created through this very intensive process. So we have some ideas about what we should be focusing on in this next year, in part driven by what you see on this driver's triangle, but also we heard quite a bit during our work group sessions with folks who were kind of saying things about, you know, how are we going to train people on this, or this makes me think differently about how I might be hiring people or what I'm looking for. I may have to go back and do some rethinking about various activities that we have as far as our hiring practices or different things that are just going to emerge, or new trainings that occurred to them. So we envision in FY17 going forward that we'll be having some additional work groups that really are going to be focusing more on the how of this work. You know, things like how do you supervise to this, those types of things that'll be organized by those key implementation drivers that you see up here on the screen. So it may involve creation of fidelity tools and those types of things. So what you heard, these are some of the ideas that emerged from those work groups organized by those drivers. So on that kind of individual competency side of the triangle, you'll see things, people suggested, work group participants suggested things like, it'd be really helpful if we had some type of online, on-demand training that everybody sat through regardless of you know, what program or what agency that they work for, that everybody kind of had a basic 101 slide deck or something to refer to. You know, people brought up trying to figure out some way to create a self-assessment around some of the cultural relevance items, creation of some practical tools or how-tos on how to do things like using a genogram or eco-maps, safety checklists. So these were all really good ideas from those practitioners that sat with us through these work groups that kind of occurred to them that need to be developed or disseminated to help support the work of the practice profile. Other things that occurred to people throughout these work groups were more organizational in nature and trying to really align some of these support activities. So things like a crosswalk of billable activities was one that came up quite frequently as we walked through the different practice elements. Crosswalking the practice profile with the different managed care review tools was another issue that emerged. And then going through that list of training requirements that are in the program specs for IHT also was something that work group participants suggested would be a helpful support going forward. And we know that these types of things often require leadership. And so part of what we're doing here is, and this webinar today, is to really try and engage stakeholders, because we know that's going to be so key to kind of continuing to make this a successful effort. So making sure that we're keeping everybody up to date, that we're including every level of kind of our provider community in doing this work. And we know also when this starts to roll out that there's going to be some work that practice leaders within your agencies are going to need to do to kind of help people understand what this is and how it can be used and that kind of thing. So that's all the work that's going to be going forward. So we really see the practice profile as not the end, but the beginning of a next step in development of IHT. So for those of you who are interested, we have a practice profile page that's on the Children's Behavioral Health Knowledge Center website. If you haven't been to it, check it out. It's at www.cbhknowledge.center is our main page, and then you can go to the IHT practice profile page on its /IHTPP. So there you'll find each one of the different matrices. You'll find the literature review is up there, and also a PDF version of the slide deck from today is already up on the website if you're interested in taking a look at that. Jack mentioned we'd be doing some focus groups with supervisors and direct care staff throughout July and August, and we'll be taking that bit of feedback and incorporating it into another revision. So what you'll see up on the center's website is where we are to date. We're still working on incorporating some feedback from various folks, and then we'll create another iteration of it sometime in the fall. And then we'll be working going forward to create an implementation plan for some of those work groups to really roll this out. Because as I said, it's kind of, this is a foundation for what we envision will be a variety of different tools and efforts to really make this usable for folks out in the field. So you'll hear more from us about this as we go forward. So at this point, we are interested in any questions that you might have for us. So you should be able to type into your text box there some questions for us that we'll see here. So if anything comes to mind, let us know, and hopefully we'll be able to answer it. So one person's asking about if the slides from the webinar will be emailed to the participants. So we do have the slides already posted up on the Knowledge Center's website, so I'm going to encourage people to go there, because what we want you to see are the slides, but also take a peek at the different matrices that are up there. Just a note to folks, if for some reason you go and the website looks weird, make sure you go in using Google Chrome. That's the magic to making the website actually look pretty. So other folks are asking, someone just asked, is can a previously uninvolved organization become involved in doing this work, and how would that be? I envision that we will have, you know, a variety of opportunities as we go forward to kind of involve folks in building this out and helping us. So I'd say the first step is kind of familiarize yourself with what we've done to date. And then as we start thinking about we're going to be working on a work plan over the summer months, and at that point, then we'll figure out a way to start engaging other folks and helping us build out some of the training activities or other fidelity tools or those types of things that we know we're going to need to create. Okay. So another question about, is it too late to become involved in the focus groups? So we worked with those agencies and organizations that were part of the development of the practice profile to be a part of the focus groups, because what we really wanted to do was have somebody there who was familiar with the development process, kind of help their staff understand what we were asking of. So. But we do think as I mentioned earlier, that we want to really try and have as inclusive a process as we can, kind of going forward, you know, as we develop, you know, training, fidelity tools, other types of things. So this won't be the last you'll hear from us with respect to this work. So someone's asking about the slides for the webinar. Again, they're up on our website, so you can go ahead and download those. There's a question that is a good one that we'll have to kind of go back and do some thinking about to what extent families have involved in this process, and how might they be involved in upcoming focus groups. So that's a good you know, piece of feedback for us to take back and think about how do we figure out some of the work and how the practice profiles kind of evolved, and get some more family perspective on that. So other questions folks are sitting with? So someone's just asking about, will there be a training provided on how to train staff on the practice profile matrices? So we envision that definitely that training part, you saw the driver triangle earlier, that training and coaching people and on how to use the matrices will be an important piece of that work. So we hope to have a work group that'll be specifically focused on training. If you go ahead and, once you go to the website and see the different matrices that are up there, you'll see in the preamble to the practice profile work, there is a bit of some language up there about how to use the matrices that's intended for some initial guidance, but we know we'll have to do more to kind of flesh that out for folks. So, so someone's asking again about the website. So if you're making sure to use Google Chrome instead of Internet Explorer, if you go in, it's www.cbhknowledge.center, and from there it's /IHTPP. Alternatively, you can find it by scrolling through the menu that's at the top. It's under the Innovation tab. It's the first page that should come up under the Innovation tab. So someone's asking about why Google Chrome. I don't know, but I think it's in part because we use Squarespace as the internet host for it, and it only talks to Google Chrome or Safari. I think you can use Safari too. You just can't use Internet Explorer. So another question about how will the practice changes affect authorization for services? So at this point in time, I don't think that the practice profile does anything to change how the services are authorized. It's simply, in part to offer guidance for practitioners about how to do the work. So how do you, if there isn't guidance, practice profile won't get you to how to talk to or interface with the managed care companies. It's more about how do you work with the kids and families. So it's not a tool that's intended to be kind of how do you deal with kind of more the administrative components of doing the work. It's more about the actual clinical aspects of the work. So someone's asking about this, is the sessions being recorded? Can we access that recording? So yes, we have been recording it so that we could share it with others who may not have been able to be with us today. So we will be getting that link up on the Knowledge Center's website and be sending it out afterwards. It may take a few days to get it up on the website, but we will have it up there for folks, and you can share that. The more people that that are part of this and hear about it, I think the better from our perspective. So share broadly. So. Other questions that are occurring to people, or anyone else, Bonnie or Jack, last thoughts, or Susan, before we sign off this afternoon?
No, I think people may have follow-up questions and they can direct them to Kelly. If there's something that occurs to you later, don't feel you missed your chance to ask a question.
So you'll see here, just on the final slide here, there's the contact information for myself and for Jack. If there are additional questions that occur to you along the way, please feel free to reach out.
Yeah, either of us.
All right. So I think that's, we've come to the end of our webinar this afternoon. I want to thank everybody for taking time out of their day to be with us and learn about this process. We're really excited and hopeful about this next stage in the work for the practice profile. We think we've gotten it to a place that it's really well specified, tons of provider input, that we think we're really hopeful about where this will bring us into this next stage of quality improvement for IHT. So thanks everybody for being with us, and we'll talk again soon.
Thanks everyone.
Thank you.
Thank you.